The purpose of this information is to help neurosurgeons to understand parts of research that will give them the ability to appreciate what the findings are that are published and whether to be able to use them in applying findings into their clinical practice. Every neurosurgeon needs to know this information, whether they actually perform any research, but because they will be reading about research that may be suggesting changes in practice from what they were trained in, or what they may have found in the past themselves. Although this is superficial in grasp, it is focused on helping with the continuing improvement in practice. The understanding of a chapter on epidemiology and biostatistics within the research area involves a spread that includes diagnostic and screening tests, establishment of causation, and evaluating intervention and preventions, as well as the examination of core concepts of mathematical analysis of data from studies aimed at the three listed approaches already mentioned. The overall requirements of what neurosurgeons need to know, and which will be discussed at this time, include the usefulness of Bayesian tables in deciphering the details brought to bear on research questions, brought to bear on the study of reliability and validity of diagnostic and screening tests used every day in the clinical care of patients, or those new ones proposed for that use. Understanding of the appropriate study designs required to explore or establish causation in clinical scenarios, and the evaluation of the utility of proposed interventional and prevention techniques while deciding to use them in the clinical care of patients. Before beginning the overall described details, let's take a clear overlook at the use of Bayesian tables, all containing different types of data, but all utilized in the appropriate way to examine information. First of all, the Bayesian table outlines the important parts of the inquiries into research questions and enables the thoughts regarding the specific research or statistical questions being worked upon. This is usually done in 2x2 tables with separation of data in ways that they can be understood and weighed as to their importance. From data showing to data examination, with the likelihood that the details found are applied in an appropriate way. One of the most useful abilities is that of utilizing 2x2 tables, Bayesian tables, to separate data so as to examine it carefully, whether in the examination of diagnostic tests, comparison of observer findings so as to understand reliability, determination of case study comparisons, and ultimate power of studies to demonstrate truth regarding findings. So let's begin with the understanding of the reliability and validity of diagnostic tests, which are an integral part of clinical practice. What we want to do is to have in epidemiology measurements of a novel test that must account for validity and precision. Validity refers to the accuracy of a test measure, whereas precision refers to the reliability of the test. Validity assessments represent the most common application of the Bayesian table, which illustrates a simplistic 2x2 chart to calculate sensitivity, specificity, positive predictive value, negative predictive value, and prevalence. In this example, cultures from reservoir aspirates are used to calculate sensitivity and specificity in diagnosing the presence or absence of infection in a patient with a malfunctioning or suspected infected shunt. We can see the impact of prevalence on positive study findings in diagnosis, first in a common disease, then in rare disease, demonstrating their difference. In this common disease example, cultures are positive in the same number of patients who are infected as they are negative in an equal number of patients who are not infected. In this example, there is a high positive level of all aspects of the categories, including sensitivity, specificity, as well as positive and negative predictive values, as well as the overall prevalence. By contrast, in a rare disease, the same abilities of the diagnostic tests are different, given the limited presence of cultures in the findings. In this circumstance, the test remains equally sensitive and specific because of the relative ability of the test. However, because of the presence and absence of the disease in this case of rarity, predictive value in being positive is noticeably reduced in the atmosphere of diminished prevalence. As we have been looking at validity, it is essential to be convinced that those who rate the presence or absence of disease, as shown by the diagnostic tests, are in agreement when they look at the findings. The larger the lack of agreement, the less useful a proposed test will be in the actual clinical care of patients. Once again, utilizing the Bayesian 2x2 table, we can calculate the agreement between observers and therefore establish the utility of such a clinical observation in determining the presence of a disease in a given patient's situation. The comparison between the assessors in terms of their observations of the finding being presence or not then shows the degree of agreement beyond chance and therefore shows whether such a test or clinical observation is actually something that can be used in clinical practice or even and especially in clinical research. It is important to understand that percent agreement between two neurosurgeons who are asked to evaluate the presence of hydrocephalus when group D is large, that is to say where the group mostly contains those who do not have any sign or perception of having those with, in this example, presence of hydrocephalus. One can also calculate agreement by removing the group in which both observers agree that there is no presence of hydrocephalus among those assessed. In this scenario, agreement is being calculated directly among all of those observations for presence or absence of hydrocephalus, utilizing whatever mechanism is being tested. Some of the agreement may be arrived at by chance alone, and those must be accounted for to determine clear utility of the observations. This is undertaken by calculating the findings in cells A and B, and C and D in terms of their contribution in terms of predictive value. In this case, those numbers are 88 and 62. In order to determine agreement by chance alone, those predictive value numbers are then used to calculate the percentages of those in cells A and D that have been determined by chance alone. This then gives us a clearer idea of the percent of agreement that can be counted upon. In addition, there's also a more complicated way to assess agreement in which the terminology goes beyond a simple 2-by-2 table. In this illustration, percent agreement between two neurosurgeons who are asked to label a finding as abnormal, suspected abnormal, doubtful abnormal, and normal can be calculated by simply comparing how many times the observers agree in all the areas being determined. In looking to understand causation for the instigating factors within patients who have certain diseases or outcomes within treatments for various circumstances, once again, one can use Bayesian tables. For example, dividing the patients within a case control study into those with given outcomes and looking at the relationship to treatments, the Bayesian approach can be utilized to try to determine causation. In this layout, odds ratios may be determined using the Fisher's exact test. So this Bayesian table assesses the effect of antibiotics on cases of cerebrospinal fluid infections, determining the cause of the outcomes. This shows that patients had a greater than 3 times greater likelihood to have infection if they had no antibiotics. Now let's look at the evaluation of the utility of proposed interventional and prevention techniques while deciding to use them in the clinical care of patients. Let's look now at the Bayesian approach for hypothesis testing. In this example, the alternative hypothesis, H1, is the difference or association between mean pediatric age and reservoir aspirate culture. By comparison, in the null hypothesis, H0, there is no difference or association between reservoir aspirate culture and lumbar puncture culture. And this shows us the presence of power of the study and type 1 and type 2 error in the study, and leads us to choose whether the study should be utilized or not. Finally, here are suggested biostatistical analyses for comparison testing, depending upon who is in the groups being compared and how they are collected and compared. It is helpful for a reading neurosurgeon to know what and why specific tests are used, even if the reader is not a detailed researcher. We hope that the overall requirements of what neurosurgeons need to know, and which have been discussed at this time, including the usefulness of Bayesian tables in deciphering the details brought to bear on research questions, understanding the study of reliability and validity of diagnostic and screening tests, understanding of the appropriate study designs required to explore or establish causation in clinical scenarios, and the evaluation of the utility of proposed interventional and prevention techniques while deciding to use them in the clinical care of patients are found to be useful for all practitioners. Your time and attention have been appreciated.